Thank you so much. We all know that ctDNA is very well accepted in lung cancer management today. The very first biomarker in ctDNA is T790M to monitor, to know whether there is an early relapse resistance, mechanism of resistance to first-line TKI. And where do we have application of liquid biopsies today? There is no application of liquid biopsy for tumor diagnosis. It is only there as a tool for prognostication and disease monitoring. And that's a very important information that we all should know, that it is not there for diagnosis. And of course, it will be helping not just in advanced stage disease patients where you can look at MRD. It can also be used to see as a periodic follow-up as you see in early treatment responses. Now, how do we check that? By looking at the mutational profile. ctDNA is also very fragile, but today we have fixative solutions which are very similar to formalin fixation, which extends the half-life of ctDNA, and ctDNA has been very well approved across multiple guidelines in terms of where it can be used as a testing when the tissue testing is not possible, there is insufficient tissue and the patient is not fit for going for another tissue biopsy. Or even you do a tissue biopsy, there is a very high risk of death for the patient. These are the three scenarios where ctDNA has been used, and from one of the studies back in 2018 with Dr. Anuradha Madam and Kumar sir, we had 200 patients, out of which 30 patients were not eligible to go for a tissue biopsy. They came very bad condition, and in that small lot of 30 patients also, we saw some 30% EGFR positivity. So that clearly demonstrates that when there is a crisis, you can use the liquid biopsy ctDNA testing for looking at biomarkers. Of course, you require a strong diagnosis. Pathologist, without pathologist eye, cannot take forward any diagnosis. However, for looking at the therapy options, you can use ctDNA. And this is a study coming from one country, Ontario's perspective. I think we will get something from India also very soon, like what each hospital or a center will have their own experience in terms of this. And where do we look at, where did all this start? It's all started because there is tumor heterogeneity. So when you do a biopsy, you are not able to, so everything for the pathologist's eye is a malignant cell, but not all malignant cells carry all tumor containing mutations. Therefore, when you do a biopsy, you are limited to the location where you capture the mutants. So when you do a ctDNA, you are able to get the holistic picture of the disease, not just from the location where you look at the biopsy, but also when the DNA bleeds into circulation. So intra-tumor and inter-tumor heterogeneity is one of the main achievements that you get with ctDNA. So where all liquid biopsy has an application in today's clinic, we all know, but I'm just going to, particularly in metastatic condition, ESMO has given recommendation that you can use a combined profiling to get a better understanding of the disease. So tissue testing with liquid biopsy for all metastatic patients definitely gives some kind of a value add. Of course, neoadjuvant treatment, followed by that, how is the treatment impact? Does it really reduce the disease burden or not? Based on what you get as biomarker at the initial baseline, you can use that for surveillance monitoring or after surgery, and again when the tumor comes back, you can again look at it and then follow up. So this is just a small data from our lab where we have two different panels. The idea is, we have to be cost effective At the same time, if there is a situation where we are looking at adding expensive drugs, are we missing something in the patient or not? In such a scenario, we cannot limit ourselves to NCCN guideline biomarkers or well-established mechanisms of resistance. We might want to look at those genes which have relevance documented in smaller clinical studies or anecdotal case studies. So this is our experience on looking at a 1200 gene panel on 52 cases where we did combined liquid biopsy and solid biopsy together. In these patients, we have found that there is a clonal heterogeneity. You are able to pick up some important biomarkers in the liquid which you were unable to pick up in the tissue biopsy, that is adding value to either therapy decisions or prognostication. I won't get into details in the interest of time, but what the take-home message here is, in broader panels also, you have a significant value add that comes in when you do a liquid biopsy profiling along with a tissue biopsy. And this is just a small data on the top mutated genes. You see that more than 90% of the time in advanced lung cancer patients, whatever mutations you see in tissue, you also see in liquid biopsy nearly 90% of the time. So 10% of the time, you may not pick up those mutations that you got in either of them, picked up in the other. And this is a small panel. So this is a cost-effective panel where you are just looking at NCCN relevant biomarkers plus tumor agnostic biomarkers and plus some markers which can give you information about the small cell transformation and other critical information that is required for treatment decisions. Even in small panels, when you do a tissue plus liquid biopsy together, you definitely see a significant value add in terms of, suppose there is a driver mutation in exon 19 at, exon 21 at L858, and then you also have a VUS at L850, but that is also somatic. It is very close to the active site pocket. The doctor must be thinking that, why is the TKI not giving full response? Because there is a neighboring somatic mutation that will impact the drug binding efficacy. So this is where broad, or rather a comprehensive understanding of the gene becomes important. We should not limit ourselves only to the well-characterized hotspot mutations. And this number is coming to nearly 15% in lung cancers, many times. So these are two cases where just to demonstrate how heterogeneity plays a very important role. This is a case of lung cancer patient diagnosed in 21 December, and initially her tissue biopsy did not have enough material, and then we rebiopsied and we got, this is actually a case from TNH only, and then she was ROS1 positive, treated, and then when we went ahead and looked at the tissue plus liquid biopsy at the time of disease progression, we found that the ROS1 fusion was detected in both tissue and liquid. However, that kinase domain mutation, which is the mechanism of resistance, was was detected only in liquid, but it was not detected in that biopsy specimen. So if this liquid was not done with the tissue when they did a rebiopsy, the information would have been missing, and we would have been scratching heads. What would be the primary mechanism of secondary mechanism of resistance that happened in this patient? Now, because of this information, the second generation and third generation ALK inhibitor, ROS1 inhibitors could be given to the patient. This is another case of combined, liquid and tissue biopsy profiling. So these are the take-home messages. As I said, we can look at the second and third generator inhibitors when you have mutations in the kinase domain, lorlatinib or repotrectinib. Now, this is another case of lung cancer. she she presented with all this. I am, in the interest of time, I'm not going into a lot of details here. Okay, she's diagnosed lung cancer. What happened? The tissue was insufficient and the doctor did not want to wait. They said, okay, let me just quickly do a liquid biopsy in parallel. In liquid biopsy, there was a ROS1 positive and they went ahead starting treatment. 6 months later, she completely, there was a remission of that lesion, and after 2 months more than that, then she slowly started developing more in the mediastinum, and then the doctor this time decided to go for a combo. I just wanted to bring out here that when they did the combo, we found an L858R. Previously, it was a ROS1 fusion, and so this particular L858R was present in both tissue and liquid biopsy. So this initially, the tissue which was inadequate, they had a pericardial effusion cell block which they gave it to us at the time of relapse. We found this mutation only in that pericardial effusion cell block. So this clearly explains that whatever new driver mutations we are identifying, at times it might be localized to certain locations in the human body. But later on it might be getting into circulation. Thank you.